Okay, we're going to talk now about the axial skeleton. Number of videos we've already done have been the appendicular skeleton. Now it's time to concentrate a little bit on the axial skeleton. And today what we're going to do in this video, we're going to talk about the thorax, particularly the sternum and the ribs. Okay, we'll talk about the vertebral column in another one of the PowerPoint videos, but in this point we just want to talk about the sternum and the ribs. For ribs first, and then go from there. Let's talk a little about the thoracic cage, though. What happens is it's the bony support of the thoracic cavity. There are a number of components that we have that involve the thoracic cage, basically the thoracic vertebrae, which again we're going to hold off until our next PowerPoint video. But there's a lot to do about the ribs. Ribs are a lot more than just a little bar that goes from back to front. Okay, we'll talk a little bit more about that. And they're connecting the front to the sternum. Okay, now the thoracic cavity is really significant in a couple different ways. Number one, first of all, it protects the vital organs that are inside, little things like the heart and the lungs and stuff like that, the aorta, the pulmonary artery, the trachea, the esophagus, number of things that are going through the thoracic cavity. Okay, and so that the bony cage, the bony wall around that thoracic cavity with the ribs, the sternum, and the vertebrae are there for a good amount of protection. However, it goes one step further than this. When we get to the respiratory section, or if you go to any of the respiratory PowerPoint videos, or when we talk about that, you're going to realize that the ribs are really significantly important in respiration. Big process of inspiration, or drawing air in, has to do with the movement of the ribs. Ribs have to go up and out, which expands the size of the chest cavity, which increases volume inside the thoracic cavity. And according to something called Boyle's law, the volume is inversely proportional to pressure. So the pressure goes down inside, which actually draws the air in. We'll talk a lot more about that process later on. So not only is the thoracic cavity and the ribs and the sternum and stuff like that very important for protective reasons, but it's also very important because it's vital and functional in regards to respiration. Okay, when people have certain types of other, if you look at someone with emphysema, instead of having a thoracic cavity, most thoracic cavities, by the way, are wider than they are deep. In other words, if I look from front to back, there's a certain dimension, but if I look from side to side, that they're much wider, probably about almost like a 2-to-1 ratio. However, if you look at somebody with emphysema, look at their chest. They have what's called a barrel chest. The anterior posterior diameter of the chest is much bigger, and part of that has to do with the fact that the motion of the ribs is not quite as good. Okay, and so we'll talk a lot more about that later on. So the ribs and the motion that we have both at the sternum as well as the vertebral column are significant when it comes down to respiration. Okay, we'll talk about that later on, though. That's something to look forward to, is going to be a big factor that we'll talk about in the pulmonary respiratory portion of the course. This is just looking at a chest X-ray, of what we see with the chest of the thoracic cavity. If we look up in here, I'll just draw a few things out. Obviously, if you look here, here's the heart. This area right here is the left ventricle. The right ventricle actually sits right in here. This we know is the diaphragm right here. Here's the diaphragm. It's the right side of the diaphragm. If you know the right side of the diaphragm is higher than the left side, okay, and the reason why it's higher is the liver takes up a lot of this spot. Okay, so that's that. This right here is the aorta, this little bulge right here. This area right here is where the right where the atrium is. Okay, the left atrium. And then these are the pulmonary vessels right in here. We'll talk more about that as pulmonary vessels. This is the right atrium right there. Right ventricle again is sitting down here on the diaphragm. We can see the trachea up in here. Okay, so we can see a number of cardiac structures. Again, right ventricle, left ventricle, right atrium, left atrium over here, aorta up in here, pulmonary vasculature, trachea. Let's get rid of that though. Okay, so that's just looking at a little bit of what we see there. What we also see here is what we're going to talk about today. We're going to talk about ribs. Okay, so when I start to look, here's rib 1, here's rib 2, rib 3, rib 4, rib 5, rib 6, rib 7, rib 8, we see rib 9, okay? And then we see them in the back. This is the anterior. Posteriorly, this is where we're seeing them back in here. You can actually see there's a posterior, that's the posterior, comes down, posterior rib, posterior rib. That's where it's attached to the vertebrae. See it up in here, and up in here, and then the first is going to be up in there. So we can see here's the first right there. And you can follow them all the way down. Okay, so those are the ribs. Okay, and we'll talk a little bit more when we get to the pulmonary section, talking about counting ribs. In other words, most X-rays that are gotten of the chest, they're in full inspiration, and which decreases the level of the diaphragm on both sides, which makes the heart more vertical, which inflates all the lungs. So you get to see the lung fields a lot better. But that's something we'll talk about later. But this is just a typical chest X-ray that we see. Let me get rid of all this stuff here. Just to sort of I'm just setting the stage right now for what's going to be coming. Here's another chest X-ray. We could see the ribs. Here's ribs. These are all ribs. Those this is something that's also interesting. When we're looking at the ribs, we see ribs that are going this way. We see ribs that are going this way. Guess what? These are the same ribs. Okay, this one's actually coming down this way. The ribs that look more horizontal are the posterior portion. They're close to the vertebrae. The ribs that are coming this way are the anterior portions. Ribs actually will angle downwards from top to bottom. They angle downwards. They're not perfect horizontal, but they're angled downwards a little bit. So basically, if I'm looking at this one right here, this rib is going to come down this way, and we can actually follow it down anteriorly this way. So we start out posterior by the vertebrae coming this way, and then finally it becomes anterior around the wall of the chest, comes down that way. So that's the way the ribs are. They're angled downwards a little bit. So let's talk a little bit more about the ribs, and more specifically about the bony architecture. We have 12 pairs of ribs. We can count them: 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, and 11, and 12 that are down there. The first 7 are called true ribs. The first 7 are called true ribs, and I'll explain that in a second. So that's 1, 2, 3, 4, 5, 6, 7. They're called true ribs. The bottom 5 are called false ribs. So 8, 9, 10, 11, and 12 are called false ribs. And I'll explain why they're called false ribs in just a second. So you have true ribs versus false ribs. True ribs. What makes it a true rib? What makes a true rib is because what happens, it attaches directly to the sternum. Here's the sternum. This is the sternum right here. That's the breastbone in the front. What happens is the ribs don't go all the way to the area of the sternum, but they actually stop. They stop, 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 stop. And what happens is then they're connected to the sternum by cartilage. So this area is all cartilage. These are called costal cartilages right here. These are all costal cartilages right here. Okay, and that should be 7. Okay, 7. What a true rib is the rib comes along, it comes to an abrupt end, it's attached to the cartilage, it comes this way. In a true rib, the cartilage and the rib attach directly to the sternum. Okay, so we see it attached there, we see it attached there, see it attached there, 3, 4, 5, 6, and 7. 7, 6, 5, 4, 3, 2, 1. So true ribs are ribs that, beginning with the first rib, attach directly to the sternum. Attached directly to the sternum by that costal cartilage. Okay, so first 7 ribs, true ribs, that connect to the sternum by the costal cartilage directly, not indirectly, directly. That's the key. As we go from the first rib is actually relatively flat. The first rib is very thin and very flat, and it's more horizontal. Okay, so in other words, if you looked at it from the side, it would be just a little sliver of a bone. If you look from the top, it's going to be very wide. Okay, because it's very thin from top to bottom. Okay, much bigger from front to back. Okay, so that's the first rib. As we go down, the ribs get bigger and bigger and bigger and bigger and bigger. Now that gets me to the false ribs. What makes a false rib a false rib? Well, again, here's 1, 2, 3, 4, 5, 6, 7, where those true ribs are attaching directly to the sternum. My false ribs attach to the rib above. So here right there, there's 8, 9, and 10, and they attach by cartilage to the rib above. So here was 7 right there, here's 6, but then here's 8 right here. And 8, let me just do it a different color, 8 is attaching to the cartilage above. So 8 attaches to 7, 9 attaches to 8, 10 attaches to 9. So those are called vertebral chondral ribs, vertebral chondral, because they go from, instead of going vertebral sternal up in here, 1 through 7, they attach from the vertebrae posteriorly to the costal cartilage of the rib above. Okay, so 1 through 7 attach directly to the sternum, right in here with the costal cartilage, but 8 attaches to 7, 9 attaches to 8, and 10 attaches to 9 above. That leaves my last two, 11 and 12. What happens, these are called floating ribs. 11 and 12 are called floating ribs because what happens is they come out and they stop. There's no costal cartilage. They just come out and they stop. That's it. There's no connection, no costal cartilage that takes it to the sternum. The only ribs that attach directly to the sternum are 1 through 10, okay? 1 through 10. And 1 through 7 are true. 8 through 10 are false. And 11 and 12 are false, but they're called floating. Okay? And basically that's the difference between the ribs. Okay? Hopefully you understand that. 12 ribs, first 7 are true ribs directly to the sternum by costal cartilage. The last 5 are false ribs. They don't attach directly to the sternum. 8, 9, and 10 are called vertebral chondral ribs because they attach to the costal cartilage of the rib above. And then 11 and 12 are called floating ribs because there's no connection to the sternum at all. Basically, they're just floating ribs. That's why they're called floating ribs. Okay? This is just a sort of an interesting picture. This is what we're talking about. You can actually see that here. So here's 1, 2, 3, 4, 5, 6, and 7. You see how what happens is they all attach directly to the area of the sternum. Here's 8 that attaches to 7. Let me do it a different color. 8 attaches to 7, 9 attaches to 8, 10 attaches to 9. Okay? Piece of cake. And that's the difference. And here is 11 and 12 sitting down here, attached only posteriorly. These are 3D CTs, and you can see the same thing. Okay? So here's 1, 2, 3, 4, 5, 6, and 7. Okay? So let's see. So that's 7, 6, 5, 4, 3, 2, 1. And then here we see where the ribs are attaching below. Hard to see on this. It's not quite as clear. But this over here really gives you a good idea in regards to true versus false ribs. And then the floating ribs. Okay? This is just, again, looking at a chest x-ray. So we're able to see the ribs. Here's the ribs are pointed out first through 8th rib. You could actually look at that on your own. So you just follow them around. Again, the part of the rib that we see that's more horizontal is the posterior area that's against, it's by the vertebrae. The part that's curved down this way is the anterior direction of the rib going towards the sternum, okay? Because again, the ribs are not horizontal. If this is the vertebrae back here and the sternum was out here, the ribs aren't horizontal, but they're actually angled downwards, okay? As they come around, okay? And that just shows that. Also, it has a lot of other things. Again, here's the diaphragm. It shows right there. This right here is called the costophrenic angle. Let me just mention that really quick. And that's down in the corner. The ribs, or the lung actually goes down in this area. It should be nice and sharp. What happens is we know that air rises, fluid falls. So if people have some type of a fluid inside the chest, an effusion or some type of drainage or blood or something like that, it fills these little gutters back here. And these little gutters get all full. So it actually comes straight across. You don't see that sharp border, but you normally should see that sharp border. If you don't, it's a problem, okay? So anyway, there's the diaphragm. Let's see, here's the left ventricle like we talked about. There's the left atrium we talked about. You know, this area right here is the area of the pulmonary trunk in here. Okay, here's the aortic arch like we talked about before. Here's the right atrium, okay. You can see a little bit of the vena cava right here, which is the vein that comes from the lower portion of the body. And here's the diaphragm with the liver that's down in here. This right here is the stomach bubble. There's a little gas that's in the stomach, and it fits makes like a little D right underneath the diaphragm, okay. So that's just showing a little bit about what we see on a chest x-ray. Now this is looking at the ribs as they're all laid out. Okay, so this would be the vertebral area right in here, and this is going towards the sternum on this side. You see here's one, and you see how they get larger as they go down, and the angle starts to change as well. Okay, the angle starts to change. Here are my floating ribs. This is 11 and 12 down here with the floating ribs. All these other ones, if you look at them, they come to a very, like an abrupt, sharp line right there. And basically that's when they meet the costal cartilage, which is that cartilage goes right to the sternum. Okay, so those are just a series of ribs in a row. Now let's talk a little about the rib, okay? The rib has a vertebral end and it has an end, a chondral end, or a costal chondral end. This is the vertebral end back here, and this is where the costal cartilage would be coming here to go to the sternum on this end. That vertebral end actually has 3 areas of connection to the vertebrae. Okay, most people wouldn't understand that. But what happens is it articulates with the thoracic vertebrae. How many? There's 12 thoracic vertebrae for 12 ribs. Makes sense. One vertebrae for each rib, or one rib for each vertebrae. Depends on if you're an optimist or pessimist or something like that. But this area in here of the rib is called the head. It's a little bit rounder area, and this area in the X-ray here would be the head. Okay, and the head actually has 2 facets on it. You really can't see it very well here, okay, but there's a little facet, and the facet is a joint. There's a facet on the top that comes this way and a facet that comes this way. They're angled to each other. What happens is the major facet would be this one right here, and that attaches. So let's say if it's the 5th rib, it attaches to the 5th thoracic vertebrae. But the top, if I looked at that head of the rib, it comes like this. So this is let's say if this is the 5th rib, it would attach to the 5th thoracic vertebrae right here. This part right here attaches to the 4th above. So when we talk about where it's attaching to the vertebrae right here, this is the vertebral body. That's the cavity right there where the spinal cord would be running in. But what happens is each head of a rib attaches to 2 vertebrae. The main one is to the same number of the rib it is, so 7 would be to the 7th thoracic vertebrae, 9 would be to the 9th thoracic vertebrae, but there's also a small little odd facet at the top that attaches to the vertebrae above. So the 5th rib, which vertebrae is attached to? Right, 5 and 4, because that little one right there is going to attach to 4. Okay, so that's what we see there. This area right here, let me get rid of those lines up there at the head. Okay, this area right here is called the neck. It's called the neck. Okay, and if obviously, like every other bone that we've talked about before, if you have a head, you also have a neck. So that's called the neck. Okay, there's also another important portion at this on the rib right here, and that's right here. There's a little tubercle on that rib. Okay, and what the tubercle does is it attaches to this part of the vertebrae. Now this is posterior, this is anterior. So the rib's going to be swinging around this way, okay? So this is posterior. Let me do it in white. This is posterior, this is anterior up in here. So again, we know we have 2 attachments here, both to the rib as the same number of the vertebrae as well as to the vertebrae above. But what happens is that little bump right there, that little tubercle dorsally attaches right here. This is the spinous process back, that thing you see right here. That's that bump you feel down the middle of your back. But coming sideways of the thoracic vertebrae, which we'll talk in our next PowerPoint video, these are called transverse processes. And what happens, that transverse process has a little joint that attaches to right where that area of the tubercle is. Okay, so that tubercle right here would be attached right there at that transverse process. Okay, so that's just another area. So let's go back up and look at our rib. We have our head. Our head's right here. Our neck's right here. Tubercle. This area right here is called the angle. Okay, this area right in here is called the angle. It's where the ribs, instead of going horizontal, start to go anteriorly. It's going mildly posterior at this point, but at this point it's making a big change. It's going to go around the curve and it's going to go more anterior. So this area right here is called the angle of the rib. It's where the rib starts to go forward towards the sternum. Okay, so again, what we have is we have the head right there with 2 facets, one for the same number of the thoracic vertebrae and one above. Here's the neck. Okay, here's the tubercle, which attached to the transverse process of the same number of vertebrae. So if this was the 5th rib, it's attaching to the body of the 5th vertebrae right there, also to the area of the transverse process of the 5th rib, but then that small odd facet on top attaches to the vertebrae, the 4th vertebrae. Okay, so hopefully that's pretty easy to understand. We talked about that, and we talked about the angle, and the angles where the ribs starting to go anteriorly towards the sternum at that point. Okay, so that's what we see basically on the architecture of a rib. This is just giving you a little idea as to what we're talking about. Okay, let's look at, and what we see here, here's a thoracic vertebrae. This is a spinous process. These things are the things that are sticking out in the back, those lumps you feel in the back. These are the transverse processes. Let me draw it in red. transverse process, 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 transverse process. And what happens is we're actually seeing that this rib right here is going to be attached to that vertebrae as a little bit to the one above, as well as that transverse process. Okay, and there are little joints in there, and these joints are able to move. The ribs have to be able to move up and down with respiration, so there are 3 little joints at the transverse process as well as to the same number of vertebrae and the one above. Okay, and this just shows the same thing that we're seeing. Here we go. Here's this. Okay, so what we see is let's just say that this is the 5th, because I guess 5's on my mind today for some reason. Here's the 5th, and we can see what happens is here's the head of the rib. Okay, so that's the head of the rib, and you can see where that head of the rib is attached to the 5th body right here, as well as a little bit to the 4th right there, and then it attaches that transverse process right there as it swings. This area right here would be the angle. Okay, and we're seeing that as well here. So when we look at here, let's say this is 5 again, we see the majority of that head, because this area right here is the head. Okay, the majority of the head attaches to the body of the 5th. So this is 5, attaches there, and a little bit will be attached to the 4th right there. So we have a little bit of attached to the 4th, most of it is attached to 5, and then back on the opposite side, here's the bottom of the transverse process. That little tubercle will be attached to the rib posteriorly. Okay, and that's how the ribs attach to the vertebrae. What's going to happen is that rib's going to come, it's going to abruptly end, and that's when that costal cartilage, or the cartilage, is going to come. It's going to attach the rib to the area of the sternum. Okay. One of the things that's really sort of cool about the rib, okay, is on the undersurface of the rib. Okay, now this is looking at the bottom, the inferior surface of the rib, a diagram. Along the bottom, there's a groove. Okay, and I'll show you a real rib that'll show you where that groove is. The internal surface is sort of concave, and there's a groove on the bottom for arteries, veins, and nerves that run right at the bottom edge of each rib. Okay, and that's really important. I don't know if you ever see, if you're one of the people who watch, Grey's Anatomy. I hate that show. My wife watches it all the time, and I do something else. I'd rather become nauseated than watching Grey's Anatomy. Anyway, when they put in, if you ever see them put in a chest tube, what happens? They don't want to get a lot of bleeding. So what they do is they feel the ribs, they feel the gap between the ribs, and they go over the top of the rib in the bottom of that little gap. Because if they go to the bottom of the rib on the top of the little gap, that's where that groove is, and that groove will have that artery, vein, and nerve, and then all of a sudden they cut into that. They try to avoid that. Okay, so the external surface of the rib is convex, and allows what are called the intercostal muscles, the muscles that go between the ribs. Inter, between, costal. Costal means rib. The muscles between the ribs, they attach to that outer surface. Okay, and then the end right here. See how it comes to like abrupt end? It's sort of flat. That's where the costal cartilage sits and attaches to that, and that costal cartilage is basically what's going to attach to the sternum eventually. Okay, so that's the costal cartilage attachment right there. This right here, because it's bone attached to cartilage, sometimes it does become either inflamed, which is called a costochondritis, or sometimes people with a blow to the chest, they'll actually get a costochondral separation where the cartilage actually breaks away from the rib. It's just like a broken rib, okay, which is actually pretty bad. I could tell you a couple stories about that, but I won't. Okay, but anyway, it's just that area could be very is vulnerable. I don't know if any of you have CPR, okay, or if you've ever tried CPR on somebody else, like if you work in a nursing home or a hospital or anything like that. But the first time you have to do CPR, okay, and you do it on somebody who's old, you start to do your chest compressions, and the first thing you feel is crunch. You feel it's a horrible feeling. I'm telling you. The first time I ever did that, I said, oh, I just broke a bunch of ribs. Actually, a lot of times what happens is people get old, the cartilage gets a little bit more calcified, and sometimes you'll just break right through that cartilage. But guess what? If you don't do the CPR, it's going to be die anyway. So the idea is they do the CPR. Okay. The thing about the costal cartilage is that it's also flexible because cartilage will bend a little bit. So that allows the ribs a little bit more movement. So it assists in that upward movement of the ribs with inspiration and the downward movement of the ribs with expiration. Okay, so it helps in regards to when the volume of the chest starts to change, this costal cartilage is basically able to stretch a little bit or is a little bit more flexible. Okay, so that helps a little bit. If the ribs were there, then the ribs aren't going to bend a whole lot, where the costal cartilage does give a little bit, does provide a little bit of a give to allow the ribs to move a lot more. Okay, so that's a little bit about the rib. Okay, and again, this is just looking at the rib. Here's the superior surface. Here's the articular area. Here's the area where it's going to meet the cartilage. This would be the angle. You can see the little tubercle sitting right down in there. Okay, here's that tubercle. Here's the head. Okay, with a couple articular surfaces. This right here, over at that very end, would be the area that's attached to the costochondral cartilage. Okay, let me attach right in here. It's going to go to the sternum that way. Okay, that's looking at the top side of the rib. Now, if I look at the bottom side of the rib, this really shows it pretty well. Look right there. See that little groove? You can see the little groove right there. Okay. There's the groove right there. There's the groove right there. And that's that little groove. And you can see it there. It's in blue. Somebody outlined it in blue up in here. That's that little groove on the undersurface of the rib where the nerve, artery, and vein will run. Okay. So therefore, what happens is someone, like I say, if they're going to do a chest tube, what they do is they don't want to go through this area, but they'll go just above the rib, on the top edge of the rib. That way they avoid that neurovascular bundle so they don't cause any damage to that bleeding and nerve irritation and stuff like that, or nerve transection or anything like that. But that's just a little groove that's normally there on the bottom side of the rib, which is supposed to be there. It's a good thing and it's important. Okay. So again, the thing that in trying to look at the physiology of the rib, again, they're able to bend. They do have, the bone will have a little bit of bend, but think about it. If I have a bone that goes from bone to bone with nothing else in between, it's not going to bend a whole lot. The cartilage really assists in that a lot when they go from where the rib stops and the cartilage continues on towards the sternum. Okay, but because of the thin nature of the rib, and you got to remember the rib is like a flat bone. We talked about flat bones earlier on, basically intramembranous ossification type of a process to be able to ossify, and you should know about that from a previous video. What happens is because the bone is sort of flat, it's able to bend a little bit, and the cartilage helps that even more. Okay, so it's able to cushion shock and absorb blows to the chest. Okay, I mean within limits. I mean you can't, you're not going to catch a rocket or something like that in your chest, but that's a little bit that. We know that what happens, ribs are tightly bound in connective tissue. Okay, and they hold the ribs together a little bit. Okay, to prevent them from going all over the place. Okay, so they does hold it. Rib fractures heal without splinting. Okay. Years ago, this is sort of interesting. Years ago, when a person had a rib fracture, what they used to do is they used to put on what's called a rib belt. They put a really tight bandage around the ribs, because what happens is when you breathe, if you've had a rib fracture, you know what it's like. Okay, when you breathe, it's a lot of pain. And the reason why people have pain with fractures is the fracture fragments start to move, and that causes discomfort. So the idea was they used to put a rib belt on so people could breathe easier. But the problem is if I don't expand my lungs, part of my lung will actually sort of squish down. It's called atelectasis. It sort of squishes down into it's like if you take a sponge, and you can take a sponge and you could squeeze it down to a much smaller size. That's what happens to the lung. Those areas are much more likely to develop infections like a pneumonia. So therefore they said, hey, you know what? Yeah, your rib fracture heals. I'm sorry you're in ICU with pneumonia. So what happens? They don't do that. I know I fractured a rib the night before I was married. Okay, we were playing football. We had a rehearsal dinner at my house, and when all the guys were playing football in my side yard, and my cousin was a big guy, he wanted to give me a little early wedding present. He hit me really hard in the chest, and my gosh, I could barely breathe for a couple weeks after that. It was bad. But anyway, that's beside the point. So I didn't put a rib belt on. I know it was fractured, and that was it. No big deal. One of the problems though is if the rib fractures in two spots, if we have the same rib that fractures in two spots, it causes what's called a flail chest. And we won't talk about that right now. But what happens is when you breathe in, instead of the ribs going up and out, that area that's broken here goes in. It gets sucked in. Okay, so it goes the opposite direction of the rest of the chest, and that's called a flail chest. So if you're ever doing an x-ray and you see a person's breathing in and the chest should go up and out, but part of it's getting sucked in, think that there's probably going to be rib fractures in there, usually multiple fractures, not usually just one rib, but a couple ribs in a row, like after a car accident or something like that. It's called a flail chest, okay? Also, if the rib is really fractured, it may become what's called comminuted. Comminuted means multiple pieces, parts. And the thing about it is, if there's a sharp area, what's inside the ribs? The lungs, okay? It may cause what's called a pneumothorax, where we get air inside the chest cavity and the lung starts to collapse because of that. So, but that doesn't usually happen with rib fractures. Most rib fractures are pretty benign, other than painful. So that's about the ribs. Okay, let's talk about the sternum. The sternum is the breastbone. We have it right here. You can see all the costal cartilages coming to the sternum right here. But the sternum is the breastbone. Has 3 parts to it. Even though it looks like one bone, it has 3 parts. It has the top part, and the top part's called the manubrium. That's that part right there. It has the second part, which is the largest portion, which is called the body. And it has a third part, which is a little thing that sticks down at the bottom, which is called the xiphoid process. So the manubrium, the body, and the xiphoid. And they have specific characteristics. And let's talk about each of them. Let's talk about the manubrium first. Here's what I want you to do. Take your finger and stick it right at the top, right at the base of the neck, and you feel that little upside down, that depression. It sits like that, and that is called the jugular notch. It's called the jugular notch. It's that shallow indentation at the top. Right next to it, and when we talked about the clavicles, right next to that, right there would be the sternoclavicular joint. So you feel that little jugular notch, and if you go just lateral on both sides of that, you feel right where the clavicle attaches to the sternum, and that's called the sternoclavicular joint. Okay. Then what happens is it looks like a shield. Okay, when you start to look at the manubrium, it looks more like a shield area. So the area that's outlined in pink up here would be the manubrium. It's wider superiorly. So if I look at the dimensions of it, it's wider superiorly, and it gets narrower as it goes towards the body. This would be the body right here. Here's the manubrium. Here's the jugular notch right there. Here's the sternoclavicular joint right there. Okay, it's wider at the top and it gets narrower as it goes down. Okay, one other thing I want to tell you about the manubrium that I think is really sort of nice is I want you to now, if you feel that jugular notch, okay, I want you to take your fingers and go downwards about 1.5 inches, okay, from that. So in other words, you could feel that jugular notch right here, okay, that little jugular notch sitting right in here, and you go down maybe about 1.5 inches to 2 inches, you're going to feel a ridge that goes right across right here. Okay, it's going to go from side to side. Okay, you can feel it go right straight across that sternum. Okay, that thing is called the sternal angle. I want you to remember that. That's called the sternal angle. Can you feel it? Hopefully you were able to feel it. It's relatively easy to feel. Now the reason why it's important is because it's where the second rib attaches. It's an anatomical landmark. So that area at the bottom of the sternum is right where the second rib attaches, and that's called the sternal angle, that area right there, the sternal angle. Okay, and I'm sure you could feel it. I mean, it's pretty easy to feel. Okay, so that's a little bit about the manubrium. The only 2 ribs that attach to it are the first rib, and right where that sternal angle is the second rib, and that's it. Okay, so and that sternal angle actually is more really body, or that, you know, or the second rib is more at the sternal body, at the body, as compared to the manubrium, but it's right where the manubrium meets the body at that point, and that's called the sternal angle. Okay. Have I got that? You look at that. See that? Good. Let's go on. Now here's the body. Now the body is this part right here. Let me outline the body. Is the body here? That's the body. Okay. It's more tongue-shaped. Okay. It's below the manubrium. Here be again. Here's the sternal angle right here. Here's the sternal angle right there. Here's the second rib, or the costal cartilage from the second rib is right there. And basically that's where all the other ribs are going to attach to. So here's 3, 4, 5, 6, and 7, just like we say. Okay, this down here is sneaking in. That's going to be 8. Down in there, that's going to be 8. Right here, that little rib right there. Okay, so you can see all the other costal cartilage attached to the body. Okay, it's actually very thin. When they actually do heart surgery, what they'll do is they'll actually come and they zip right up the middle. If they open it up, they'll split the sternum this way, and then they stick like a wedge in between, and they ratchet it open. It opens up so I could get inside to the mediastinum, that center section of the heart of the chest, which you should know what the mediastinum is from an earlier PowerPoint video or earlier lecture. Okay, and then what they do is when they finish, they just drill holes. They just take and drill a hole. And what they do is they pass a wire through there, and then they twist tie it. They bring the sternum together and just twist tie it. Okay, and then they tuck the end of the tail of when they twist tie it back in one of the holes, so it's out of the way. Okay, you might see that on an X-ray somewhere where you'll see wires across the sternum. You'll actually see them. They'll be going across the sternum like this, and basically that's after when they went in through the sternotomy. Sterno means sternum, otomy means cut into. When they do a sternotomy, they hold it together by the wires. Okay, so anyway, that's a little bit about that. That's the body of the sternum. On the bottom part down in here, this is the xiphoid. Sometimes it has a hole in the middle of it, sometimes it's a point. If you take your fingers and you feel where the ribs are coming together at the bottom, you actually feel a little piece of bone that sticks down below that. And then sometimes actually when you press on it, it'll actually click a little bit. I don't know if maybe you're easily amused or something like that, and you don't have anything to do, and you can sit there and click on your sternum, but basically on the xiphoid. But that's what it is. And it does serve a purpose, because when we get to the abdomen, when you talk about the abdomen, some of the fascial structures and muscles will have their origin right around that area of the xiphoid. Okay, so and also the diaphragm will be attaching on the inside. The big muscle that goes. If you look down the middle, I'd show you, but I don't want to take my sweatshirt off. They have the washboard abdomens. Yeah, and you're sitting there saying, yeah, right. Okay, I've never seen those on me. But anyway, if I look at, that's called the rectus abdominis. Those washboard abdomen. And what happens is there's actually two layers. That's a bad. That wasn't a good way to do it. Okay, there's actually a row here and a row here. Okay, and there's a band that connects to the middle, which is called the linea alba. Linea alba, okay, and it means white line. Linea means line, and alba means white. It's right down the middle of the abdomen, and then what happens is the muscle is divided into little segments of muscle belly all the way down, and part of that has attachment to the area of the xiphoid. Okay, but besides that, that's the xiphoid, something to play around with if you're bored. Okay, so that's that. It's the smallest portion. So again, if I'm looking at that, here's my manubrium. Here's my sternal angle right there, okay? Second rib. Here's my body of the sternum, and here's the xiphoid, okay? 3 parts. I actually was working with a baseball team, and we were playing in Detroit, okay? And one of our players was going into second base to try to break up a double play, and the shortstop took the relay from the second baseman to start the double play. And when he came across the bag, the guy, you try to get in front so the guy will throw it by your ear and get to the first base. Well, guess what? The shortstop says, I'm going to teach this guy, and he pegged him right smack in the middle of the chest. And it turns out that the kid got a fractured sternum right in the middle. Nothing much to do with it. You just sort of let it heal, but it was pretty touchy. Okay, but that's the sternum. Okay, this is again looking at, here's the manubrium, here's the body, here's the xiphoid down in here, and this is another 3D CT, and you can see that's bad using red on red. Here's the manubrium, here's the body, and here's the xiphoid down in there. You can see the ribs coming in there, and this red area would be the area of the costal cartilages. Okay, this is looking at it from the side, and you can see how remember we talked about intramembranous ossification with flat bones. You can actually see it. So if we look here, there's an outer plate, there's an inner plate right there, and everything in the middle is that cancellous bone. So I have cortical bone on the outside, an outer plate, and a cortical bone on the inside, that inner plate, and then the area of the green right down the middle is going to be that cancellous bone, which is that flat type of bone configuration. You can also see right here, you see the gap right there? That's the area of the sternal angle. Okay, that's where so this area right up in here, this is the manubrium, and this is the body. Okay, so that's what we see with the sternal angle. That's bad, black on black. Sternal angle right at that point. Okay, hopefully you're able to see all that. Pretty obvious, I think. This is just another CT scan looking at the sternum. So here's the manubrium, here's the body, here's the xiphoid down here. You can't see the xiphoid, we're out of the plane. You gotta remember the CT scans are done in slices. Okay, so if something's not in that slice, guess what? You don't see it. It has to be in that slice, that width of that slice, which is usually maybe a ½ centimeter or something like that. Some of them actually are 2 millimeters. They're very, very thin. Depends upon what the quality of the scanner as well as what you ask for. But you don't see the xiphoid down here. You know, it's not that it's, you know, that somebody took it. It's just that it's out of that plane. Here's the body. Here's the manubrium. Okay, and this area right here. You can actually see where the clavicle is coming in up there. You can see the clavicle here. So if we look here, here's the clavicle. Here's the clavicle. There's the manubrium and the body. Sternal angle right there. Xiphoid. Okay, that should be pretty easy to figure those out. Very easy bone, not very difficult. And the thing that's interesting, you actually see a couple good things here on the picture on the right. Okay, what we actually see here, if you look, see right there, right there, right there, right there, right there, right there. That's the end of the bone. That's the end of the bone. That's where the rib comes to an abrupt end. But then what happens is, if I'm looking, I see a haze right here. I see the haze right there. The haze right there. Haze, haze. What's that? That's that cartilage. The cartilage is not nearly as dense as the bone. Look at the density of the bone. See, it's a little bit more white. It's still gray, but it's a little more white. And the area in here where the cartilage is a little bit more amorphous. And you actually see right here at that sternal angle, right where that second rib attaches to. Okay, so that's pretty easy to see. And you can also see down here, here's costal cartilage, there's costal cartilage, costal cartilage, costal cartilage as well. Okay, so you can see how that looks. That's how how a costal cartilage would look like on X-ray. It has a different density. The bone is going to be more dense, so therefore it's going to be a little bit whiter. The cartilage is less dense, so it's going to be a little bit grayer. Okay, so hopefully you see all that. Here's the sternoclavicular joint. Sternoclavicular joint. You get sort of the appearance that that's more of a rounded type of portion of the clavicle up in that area. Okay. So what have we talked about today? We've talked about the ribs as well as the sternum. You know, pretty self-explanatory. There's really not a whole lot that goes on there. We know that the rib has 3 attachments for most ribs, not all ribs, but most of the ribs. When I get down to 11 and 12, we start to change that. But and 1 also is a little bit different. But 2 through 10 and sometimes 11 will have 3 attachments. 2 to the same number of the vertebrae and 1 to the vertebrae above. That little, what's called a demifacet, which is just on the top. Okay, very small. Okay, we know that there's the head, there's the neck, and that tubercle, and the tubercle which attaches that transverse process of the vertebrae. Okay, we know there's angle where it starts to go from posterior to anterior. We know it stops. We know what true ribs are. The first 7 because they attach directly with a cartilage to the sternum. 8, 9, and 10, 11, and 12 are called false ribs because they attach. 8, 9, 10 attach the rib to the cartilage of the rib above, okay, but not directly to the sternum. And then 11 and 12 are called floating ribs because they don't attach to anything anteriorly, okay. Sternum, manubrium, body, xiphoid. Where the manubrium meets the body is called the sternal angle, which is right where the second rib is. The top, which is that little notch, is called the jugular notch. We could feel the sternoclavicular joint right at the both sides, that just lateral to the jugular notch on both sides. Okay. Again, this is going to be really important to understand how the ribs work. Because again, it's significantly important in respiration. We talked about how the ribs are not just important for protection of the viscera or organs in the chest cavity, but also very important for in respiration because the ribs have to be able to move. If there's some type of, if you see somebody with a big hump, okay, we'll talk a little about kyphosis. Kyphosis is somebody who has this big hump in the back, or sometimes a scoliosis, where it's a side-to-side curve. What happens is it destroys some of those articular facets between the ribs and the vertebrae, which then interferes with the ability to breathe. Okay, and that's just something you could think about a little bit later. Okay, again, if you have any questions about any of this material, you could always send me an email and I can answer that for you. Other than that, because you can't ask a question through the video, again, as always, be safe and be healthy. Okay, and we'll talk to you with our next video.